Welcome to part 2 of the Afro-Vegan Society speaker series featuring Dr. Priyamvada Naik, the Veg Doc, presenting on COVID-19 and the risks to Black and Brown communities. This education session is made possible thanks to our sponsors, Better Food Foundation, A Well-Fed World, and Veg Fund. Afro-Vegan Society is helping disempowered communities take back control of their health and environments through vegan living. Support our work and visit afrovegansociety.org/get-involved to donate.
Hi everyone, my name is Dr. Priyamvada Naik. I am a board-certified physician in pulmonary medicine, critical care medicine, and lifestyle medicine. Brenda had asked me to talk to folks about the racial disparities that we're seeing with COVID-19 in Black and Brown communities. So I thank her for that opportunity. We've split up the talk into 2 parts, so hopefully you guys have already watched part 1, which is where I address what COVID-19 actually is, the disease process that is occurring due to this, why it's so important that we physically distance, and what the treatment options are at this time. But part 2 is really where we're going to get into the real bones of why this seems to be hitting people of color particularly hard. Okay, so as I go through the talk, if you guys have questions, write them down. I'm happy to talk with Brenda about it at a later date to figure out how we can answer those questions. I do want to preface this by saying that the data that I'm talking about, I think most of the people watching this are probably already aware and unfortunately are experiencing these statistics. So I want to first of all acknowledge that while I'm talking about statistics really are because of groups of people. So I realize that there are real people behind these statistics. And I also want to make sure that people understand that, this is the stuff that I'm going to talk about is pretty shocking and pretty depressing. And it's infuriating. So I'm hoping that at the end, I can end on a little bit more of a positive note where I talk about some things that we can do to empower ourselves to make some changes that can help to protect us. So when we talk about racial disparities, part of the problem that we're having is we don't have great data. And when I say we don't have great data, that's because the CDC and other organizations just were not collecting data on race. As an example, currently the CDC's data is based on the fact that 40% of the recorded deaths that they have state the race. Now, a couple independent organizations have happily stepped in and done a lot of the legwork. So there's a group called APM Research Lab, and you can see the website here on this slide. And they actually have done an excellent job of collating data on race to give us some really, really scary information, but very important information. And so what they're finding is that African-American death rates are nearly 3 times that of white death rates. And it gets worse in some states. So in Kansas, it's 7 times the death rate. In Washington, D.C., Black people are 6 times more likely to die. Now, I'm going to interrupt myself here for a second and just say that you might hear me use the terms African-American and Black interchangeably, and you might hear me use the terms Latino or Latina and Hispanic interchangeably. And part of that is because I tend to use the term African-American as an example, but often studies refer to people as Black or white or Hispanic. And so I might use the term that the study is using because it's going to make more sense when you're looking at the graphics that I'm presenting. So going back to this data, Michigan and Missouri is 5 times the rate of death if you're an African-American. In New York, Illinois, and Louisiana, it's 3 times the rate. So this is not something that anybody is making up. This is a real scary trend that we're seeing. And there are a lot of very complex reasons why that is the case. So looking at some more data from APM, their paper that they put out is called The Color of Coronavirus. What they did is they collected data on death rates, and they were actually able to collect 88% of the information on race, unlike the CDC, again, which they were only collecting about 40% of information. The data does not come from every state, but it comes from a vast majority. It comes from 40 states plus the District of Columbia. And what they found is that if you are African American, you are 2.4 times more likely to die from COVID-19. So what that means is 1 in 2,000 African Americans has died of COVID-19. That's approximately 50 people per 100,000 people, okay? If you are Asian or Latino, it's about 2.2 times as high, or 1 in 4,300, or about 23 people per 100,000, okay? Now, the data was not conclusive for indigenous communities, and part of that is because, and you'll see that theme throughout this talk, you'll see in a lot of places that we don't have enough data on indigenous communities that are often split up as the acronym AIAN, which stands for American Indian or Alaska Native, and you might see NHOPI, which stands for Native Hawaiian or other Pacific Islander. And a lot of this is because people will just check off other on the death certificate, or the death certificate may not have that option. I remember when I moved to South Carolina as a teenager and I got my first driver's license, I listed my race as Chinese because my options were black, white, Chinese, or other. And I was like, well, China's close to India, so I'll put Chinese down. So you can imagine that if you're not given that option to represent yourself, that's a real problem when we're trying to collect data on representation. But what we do know is the Navajo Nation right now has some of the highest mortality of anybody. They have 5 times the rate of mortality amongst Native Americans. And in New Mexico, we're seeing rates of 7 times as high amongst Native Americans. Now, what these guys calculated, what they figured out was that if you were to somehow normalize the data for race, if you were able to sort of compare them to white patients, white counterparts, if the rates were similar, there would be 12,000 less deaths amongst African Americans, 1,300 less deaths amongst Latinos, and 300 less deaths amongst Asians and Asian Americans. So this is, I mean, these are thousands of people that are dying disproportionately compared to their white counterparts. So there's a wide variety of reasons for that. And at the end of this talk, I'm going to give you kind of a summary slide that really looks at all of the different levels of things that determine healthcare and how, and as we go through the slides, you'll see how at every level people of color are disadvantaged. So there are systemic and societal reasons, there's economic challenges, there's access to healthcare issues, there's prevalence of comorbid diseases. So comorbid means associated diseases like type 2 diabetes, heart disease, pulmonary disease, things like that, that we know are causing increased rates of death for COVID-19 in particular. On top of that, we know that people of color often have worse outcomes from the same comorbid diseases as their white counterparts. And then, of course, there are specific issues related to COVID-19 that I'm going to talk about, and then specific issues related to ARDS, which, if you recall from part 1, is what we see a lot of when we see severe disease with ARDS, with COVID-19. So let's talk a little bit about systemic issues. So there's a lot of data out there on race, but I did want to point out one small piece of data on gender. So women make up half the workforce, but 64% of all frontline workers. The vast majority of these folks are folks that are face-to-face to people who are high risk of being ill. So if you're a cashier, if you work retail, if you work customer service, if you're a pharmacy tech, you don't have the luxury of being at home, and you are constantly exposed to people. 67% of people are fast food workers. So if you're going through the drive-through, the person working that drive-through is most likely to be a woman. 77% of healthcare workers and 87% of people who work in childcare or social work are women. So this is another disparity where we're seeing disproportionate groups of people who are vulnerable to disease being in high-risk jobs. So if you look at race, 40% of frontline workers are non-white. 1/6 of frontline workers are immigrants, and the vast majority of those are in cleaning services. There is a decent amount of physicians, though, that are immigrants, 29%, although there is a somewhat xenophobic move in America to stop allowing H-1 visas and things like that. H-1 visas are how a lot of physicians come to America and practice. Look at this last one. Workers of color make up nearly 60% of transit workers. If you're a transit worker, you have no way of protecting yourself in a reasonable fashion from any infectious disease. So you are most likely to be a person of color if you are a transit worker. So you can imagine this is one of the many reasons why people who are dying of COVID-19, people who are getting COVID-19 are disproportionately people of color. So workers of color also make up the majority of the top 10 occupations in the trucking, warehouse, postal industries, in building cleaning services, and again in healthcare. Now, when people look at labor force and various industries, they often break them down into 5 to 10 different subheadings within that group. So the interesting thing about healthcare is, although workers of color make up the majority of the top 10 occupations within healthcare, the exception to that is nurses, physicians, managers, secretaries, and administration. So again, it tends to be the lower wage workers, okay? 1/3 of people currently working the front line are over age 50. 1/6 of them are age 65, or they live with someone who is over age 65. So if you're a cashier and you're at high risk for contracting the disease, you're also at high risk of bringing it home if you live with someone who's older and at risk for a poorer outcome. And then again, 1/3 of folks have family care obligations like a minor child. Now, the Bureau of Labor Statistics in 2018 said that 78% of the labor force is white and 13% are Black or Asian. So when I say labor force, that's not manual labor or menial labor. It's just anybody who can work and who is of the age that they are able to work, okay? So 78% of people are white, 13% are Black and Asian, and yet disproportionately, 60% of transit workers, as I already said, are workers of color. So there's clearly already a system in place that disproportionately is unfavorable to people of color. So this is a table looking at, and this is from the Kaiser Family Foundation. And it shows, again, this is just more data showing that people of color are disproportionately on the front lines. And on top of that, they are, again, disproportionately low-wage jobs. So this isn't people of color are disproportionately physicians and they're on the front lines. This is people who are working jobs where they're not making much money. They may or may not have health care. They likely don't have sick pay, and they're in high-risk positions from the standpoint of exposures. So if you look at the demographics of low-wage workers compared to all workers, again, disproportionately, you're seeing Hispanic people and African Americans tend to have a higher proportion of low-wage workers compared to all workers. And again, females tend to be in the highest group of low-wage workers. So when we talk about economics and healthcare, it's a little bit hard to split them up into neat boxes. So you're going to see a little bit of blurring of some of these slides where I'm talking a little bit about healthcare and a little bit about economics. So the Commonwealth Fund is a group that looked at reducing racial and ethnic disparities in access to healthcare, specifically as it related to the implementation of the Affordable Care Act, or what people call Obamacare. So they looked at access to healthcare as well as outcomes, and what they found, and this was confirmed by the Kaiser Family Foundation's study as well, was that prior to the ACA, or the Affordable Care Act, access to healthcare was worse for Black, Asian, and Hispanic populations. The Commonwealth Fund specifically showed that between 2013 and 2015, so after the implementation of the Affordable Care Act, there was a narrowing in the gap of people who were uninsured, people who skipped care because they might now have insurance, but they were underinsured, so they couldn't really afford their bills, even if they did have insurance. Or they might not have had a regular healthcare provider, so they might have skipped care. That disparity between people of color and their white counterparts started to narrow with the implementation of the ACA. They also saw that when states expanded Medicaid, there was a narrowing of that gap in racial disparities as well. And I want you to remember that because we're going to come back to that in quite a few other slides, the importance of the expansion of Medicaid. What they also found was that the ACA did, to some degree, show increased access to healthcare, reduced racial and ethnic disparities, as we've already talked about. But there's a caveat to this, and I'm going to go over that now. So these are two quite busy slides. I want you to focus on the first one, which is figure 1, the figure on the left. So I'm going to kind of talk you through this graph. So what this graph is basically looking at is if you look at every race, white, Black, Hispanic, Asian, and then again, AIAN stands for American Indian and Alaskan Native, NHOPI stands for Native Hawaiian or other Pacific Islander. So what this graph is attempting to show is they're looking at what measures changed, what measures got worse, what measures got better, and what measures didn't change at all with the implementation of the Affordable Care Act. And they looked at 10 different parameters. And what they found is across the board, if you were Black, if you were Hispanic, you did have some parameters improved. That's the dark blue. So if you look at the bar for Black people, the bar says that 6 parameters improved. That's the dark blue. 4 didn't change and 2 got worse. Okay. Now across the board, things improved. If you look at the white counterpart bar, you see that 5 parameters improved for them. But again, remember I said there's a caveat to that. Let's look at figure 2. So figure 2 is now comparing Black people, Hispanic people, Asian people, AIAN, and NHOPI to white people. That's why there's no white bar here. And what this graph is looking at is the comparison. Did they do as well as white people? Were the improvements the same? And unfortunately, they weren't. Now, all of a sudden, we're seeing a larger proportion of orange in the bar. And orange was the number of measures that got worse when compared to white people. So although overall there was improved access, there is still a disproportionate, relative worsening of care. Sorry, I shouldn't say that. They do relatively worse in a variety of parameters when compared to white people. So it's not that they are getting worse. It's that even though they are getting more access to healthcare, it is still worse than their white counterparts. So if you look at health insurance and the ACA, 1/5 of people, despite the ACA, lacked healthcare coverage in 2018. 1/5 of workers were covered by Medicaid, and 45% of people, so nearly half of people who are insured, rely on their employer for healthcare coverage. Given that we are seeing unprecedented historic amounts of unemployment right now, that's really important to know. As we've talked about before, the vast majority of frontline workers are low-income workers. If you lose your job, even if you had healthcare, you probably cannot afford COBRA payments. When I transitioned from one job to another, there was a brief period where I needed to go on COBRA. My premium doubled on COBRA. So this is not something that's just like, oh, well, you lose your job, whatever, you can go on COBRA. That's not necessarily available to everybody. The other challenge is if you lose your job and you happen to qualify for unemployment and you get unemployment, it can actually in some ways make it a little more challenging to get insurance. And I'm going to talk about that in a minute. So if you look at once people did get healthcare, so remember we said that many people, although we narrowed the gap of coverage, what is that meaning from a practical standpoint? Is coverage enough? Does it actually mean that people are accessing healthcare more frequently? And unfortunately, when you look in 2018, when you looked at the various racial groups, by, pretty dramatic amounts depending on the race, we definitely see that people of color tend not to see a doctor due to cost, whether they have insurance or not. They're delaying care for a variety of other reasons, and that can be things like they just didn't have the time. They're a frontline worker and they couldn't get the time off. They're taking care of someone at home, so they don't have the time to take care of themselves. They may not have their own PCP. And oftentimes that's because the copay is something that is prohibitive for them. So just because we have the ACA and we are seeing more coverage, that isn't always translating to actual practical benefits for patients when it comes to healthcare, particularly if you're a person of color. So remember I talked about Medicaid and I said that what the Commonwealth Fund study in 2017 showed that in states where they expanded Medicaid, they definitely narrowed that gap of racial disparity between people of color and their white counterparts. This is another busy slide, so I'm going to talk you through it. So what this slide is showing is, if you look at every state, you'll see that some states are different shades of blue. The darker the blue, the larger the proportion of Black people in that state. So unsurprisingly, in the southern US, that's where the highest proportion, that's where each state has the highest proportion of a Black population. So if it's dark blue, it's greater than 15%. The sort of middle blue color is between 5 and 15%. But if you look at the map, you'll notice that some of the states have a red border around them. The red border states are the states that did not choose to expand Medicaid. Now remember, the importance of expanding Medicaid is what? We clearly see that when you expand Medicaid, you get healthcare to more people and you narrow that racial disparity gap, okay? It's especially important if you're a low income wage earner, right? Unfortunately, the places where you are most likely to be in a large population of people of color, particularly Black people, are the states that by and large did not expand Medicaid. So you have a large proportion of Black people who we already know tend to be transit workers, frontline workers, low-income workers who are uninsured or underinsured. And now we haven't expanded Medicaid, which we know can narrow the gap. So given the systemic dismantling of the ACA since its inception, do we have any newer data? So what I mean by that is a lot of the data I've shown you so far, some of it's from 2020, some of it's from further back, but we know basically since its inception that there's been political pressure to dismantle it, and they have slowly chipped away at some of the protections in the ACA. Well, this group did a report that was published in 2020, and it showed that unfortunately we're still seeing the same things. We're seeing that 10 to 30% of workers, particularly in building cleaning services, are uninsured. So think about for a minute, we're in the middle of a pandemic. Hospitals are at record highs as far as having patients in the hospital with infections and other diseases. And the people cleaning the hospital, who are arguably the most important people in a hospital, right? You can't be in a building where you're constantly exposed to bodily fluids and not have great respect for environmental services, right? And yet these are the folks that are likely to be uninsured. The people who are most likely to contract something because they're in a high-risk position. So another thing that's important, remember we talked about Medicaid. Another thing that's important when we look at Medicaid is the uninsured are often not eligible for special enrollment periods through the federal marketplace. So what that means is in 32 states, if you lose your job and you go on unemployment, if your unemployment income is a certain amount, you're no longer eligible for Medicaid, right? Because you are outside of the income range to qualify for Medicaid. But in 32 states, you are not eligible to enroll in insurance because you've lost your job. You have to wait until the enrollment period, which is in November, in which also there's been a concerted effort to sort of hide from people, right? Like it's no longer being advertised by this administration. It's no longer being, made user-friendly. So there are a lot of people who have lost their jobs now who just don't qualify because they fall in that middle group where they don't qualify for Medicaid, and now they have to wait until November to qualify for getting insurance through the ACA. So let's go back a little bit and talk about some more economic stuff, newer data on economics. So as of 2020, 1/4 of frontline workers are low income. That's defined as less than 200% of the poverty level. And more than 1/3 of these folks who are working frontline jobs are working in grocery, convenience store, drugstore, trucking, warehouse, postal, building cleaning services, healthcare, childcare, and social services. So these fractions that you're seeing next to that, remember I said that there's sort of 10 different breakdowns within each industry. If you look at grocery store, convenience stores, and drugstores, 60% of people who work in that are low income. 50% of people who work in childcare and social services are low income. So again, the theme here, unfortunately, is if you work in a high-risk position, you are more likely to be a person of color, and you are more likely to be in a low-income job, and you are more likely to not have healthcare insurance, which is a triple threat in an incredibly negative way. So I'm going to go back a little bit because right now we're still collecting data on what the economic recession is going to do for for people in general and people of color. But we do have data from a fairly recent recession. So in the 2008 recession, there was a 10% unemployment rate overall. And we believe that now the rate currently is likely going to be higher than the 2008 recession. But if you look at race, again, people of color were disproportionately unemployed. The national average was 10%. If you were Black, it was nearly 17%. If you were American Indian or an Alaskan Native, 15%. If you were Hispanic, 13%. Okay? Let's talk about wealth for a minute. During the recession, Black and Hispanic homes lost 48% and 36% of wealth, respectively. So Black people lost 48%, Hispanic people lost 36%. Compared to their white counterparts, that's a dramatic increase. White homes lost about 24% of their wealth. So you start out low income, you lose more of your wealth during a recession, and you're disproportionately laid off, let go, whatever, during a recession. And again, you have access to healthcare issues and access to insurance issues. This is obviously a horrible combination and certainly is a large contributing factor to why people are doing poorly with COVID-19. Another thing that's kind of shocking but important to talk about is assets and liquidity. So meaning, if you were to lose your job today, do you have cash on hand or assets that you can liquefy that would allow you to pay your bills, buy groceries, feed your family, pay your insurance, pay for your mortgage, things like that, pay for a medical emergency? The average net worth of Black and Latino families currently $17,000 and $20,000 respectively. For white people, it's 10 times that amount, $171,000. Now, the caveat to this is because white people are the majority and 1%ers are disproportionate, and 3%ers and 5%ers are disproportionately white, there is a little bit of pulling of that number to the higher side by these high income earners. But the argument still remains, even if you take those people out of the calculations and you only look at people in the lowest 80 or 90% of people, you're still likely looking at numbers in the 50,000, 60,000 range, which is still twice the amount of someone who is non-white. And again, this is all related to previous recessions. So you can imagine that this is, you can extrapolate this to the current recession. Another thing that we need to look at is, if you look at African American eviction rates, currently it's 4 times the national average. And this is when you control for poverty and income. So if you are an African American person, compared to a white person who makes the same amount of money or lives to the same degree of poverty, you are 4 times more likely to be evicted from your home. This is not, there's no explanation for this other than systemic racism, right? And the problem, of course, is that this affects a wide variety of things, particularly during a pandemic. It leaves people particularly vulnerable. We also know, of course, that decades of segregation and discriminatory housing policies have led to 2 major issues in housing: substandard housing and high density housing. And if you're looking at a pandemic where you're trying to physically distance, that's a problem. So I'm going to switch gears for just a minute. So we've talked a little bit about systemic issues. We've talked about healthcare disparities. We've talked about economic disparities. I want to talk about disease prevalence and disparities in disease processes, because we do know, again, that if you have heart disease, if you have lung disease, if you have type 2 diabetes, if you're immunocompromised, if you have cancer, you're disproportionately likely to have a poorer outcome with COVID-19. What we do know is that non-whites have disproportionately high rates of asthma, diabetes, heart disease, and a couple other disease processes that I'm going to show you. So this is just one piece of data looking at this. This isn't new information. This is actually a graph from 1999 looking at the disproportionate rates of hypertension, meaning high blood pressure, hypercholesterolemia, and when they say diabetes, they specifically mean type 2 diabetes amongst all races. And if you look at the second graph in amongst each section, that's essentially white people. And then the next graph over is African Americans. And then the next one is Mexican Americans, okay? And you can see that by and large, at every marker, Black people have disproportionately higher rates. There are a couple exceptions. So for example, hypercholesterolemia, for whatever reason, they're about the same. If you look at 2020 data on these three disease processes, the numbers are nearly identical as they are now. So since 1999, nothing has changed. We're still seeing dramatic differences in prevalence of these diseases. Let's talk about heart disease, the #1 killer in America globally. The #1 killer of Americans, So we know that if you are African American or if you are Hispanic, you have a higher rate of heart disease, 47% and 30%. These percentages are expected to increase by 2035. So we expect more than 47% of African Americans are going to have heart disease. According to the American Heart Association, if you are Black, you are 2 to 3 times more likely to die from heart disease than your white counterparts. And there are a wide variety of reasons for this: access to health care, insurance issues. But there are also things related to risk factors for heart disease. So let's talk about risk factors for heart disease. So the top risk factors for heart disease are things like smoking. Do you have type 2 diabetes? Do you have high blood pressure? Do you have high cholesterol? Okay, so Dr. Ferdinand published this data in 2015. He is a phenomenal African-American physician who does really great research on racial and ethnic disparities. And what this study looked at is disparities in outcomes amongst African Americans and white people with diabetes, high blood pressure, and high cholesterol, and hospitalization rates. And what they found is that if you are African American, you are less likely to have good blood sugar control if you have type 2 diabetes than your white counterparts. You are less likely to have good control of your cholesterol and your blood pressure if you have high blood pressure and high cholesterol if you are Black than if you are white. You are also more likely to be hospitalized if you are Black. So if you are Black, you are more likely to have poorer control of disease. You are more likely to be put in the hospital for disease, but you're likely to be underinsured or uninsured, and you're likely to have low income. So you're going to have astronomical bills that you cannot afford. And you're also likely to not have a housing situation that is as secure. Let's talk about some issues unique to the diseases themselves, like hypertension. So there is a group in Alabama, in the University of Alabama in Birmingham, and they're putting out data from something called the REGARDS database. And REGARDS stands for Reasons for Geographical and Reasons for Geographical and Racial Differences in Stroke. Okay, that's what REGARDS stands for. And what these folks are looking at is patterns of racial and ethnic disparities for hypertension and stroke and heart disease. And what they found is that if you have high blood pressure and you are a 45-year-old African-American male, you are nearly 3 times more likely to have a stroke at the age of 45 than your white counterpart with the same degree of high blood pressure. But what they also found was this had nothing to do with socioeconomic status or access to healthcare. If you look at a white person and a Black person, and they both have the same level of income, they have the same level of access to healthcare, and they have the same blood pressure, but you are a Black man, you are nearly 3 times more likely to have a stroke. Why is that? Something called the Southern diet. What is the Southern diet? The Southern diet is fried foods, salty foods, and animal products. So that's good news and bad news. I mean, the good news is some of this stuff is under our control. But the bad news is we're still seeing astronomically disproportionate rate things like stroke, which is obviously very debilitating at the age of 45. So let's talk a little bit about smoking and obesity. Okay, so remember I said smoking is a big risk factor for heart disease. Thankfully, we're not seeing disproportionate rates of smoking amongst Black patients, Hispanic patients, and Asian patients. Unfortunately, if you are American Indian, Alaskan Native, or you are a Native Hawaiian, you do have higher rates. but not necessarily related to your white counterparts. If you look at figure 35, if you look at the arrow, that's pointing to percentage of people who are obese by race. And you can see, once again, Asians have the lowest rate of obesity, but white people are the second lowest. And if you are in any other group other than those two, you do have disproportionate rates of obesity. And unfortunately, this translates to children. That's what figure 36 is showing. If you are between the ages of 2 to 19, you have disproportionately high rates of obesity amongst children as compared to your white counterparts. Now, for some groups, there was no data available. And again, obesity is a risk factor for heart disease and stroke. What's important to understand is when I present this data, it is not in an attempt to fat shame or victim blame people for these disease processes. We know that many of these disease processes, particularly something like obesity, are directly related to things like poverty and low income and access to food and things like that. So let's talk about asthma. So if you are African American and you are a teenager, you are much more likely to have asthma than your white counterparts. And remember, lung disease, risk factor for COVID-19. Why is that? So again, this is a super busy slide and I debated putting it in, but I think it's a really important slide that looks at really important data. So I'm going to try to break it down for you. So if you see, I've put in these black arrows, these sort of black dividers, where between each divider, you're seeing two bar graphs. What each bar graph is looking at is each section is divided by race. So the first two bars are related to Black people, the second two are Hispanic, and the third are white or other. And within each group, you're seeing two bars. The first bar is the amount of pollution that is caused by that racial group. The second bar is the amount that racial group is exposed to. So this is a graph that is looking at something called pollution inequity. So if you look at the first two bars, what we're looking at is we are seeing that compared to the amount of pollution that Black people are responsible for, they are exposed to far more pollution than they're actually responsible for creating. Look at Hispanic people, it's the same thing. And the actual numbers are very different, okay? So the actual numbers, hang on, I gotta move this because I'm not able to actually see my numbers. So I apologize, I can't actually see the numbers. I'm seeing an image there and I can't figure out how to move it. But you can see the percentages there that African Americans and Hispanics disproportionately are exposed to more pollution than they are responsible for causing. Conversely, Caucasians, non-Hispanic whites, experience a 17% lower exposure compared to what they cause. So they actually have a pollution advantage. So why am I talking about this? Well, we just talked about asthma, right? You can imagine that if you live in a polluted area, you have higher rates of asthma. In fact, one of my old mentors won a CDC award for showing that if you are a Mexican child exposed to pollution, there are higher rates of asthma in those areas. But there's another reason that we need to talk about pollution. Pollution, according to the World Health Organization, is associated with 1/3 of heart disease deaths, 1/3 of lung cancer deaths, and 1/3 of stroke deaths. That's 4.2 million deaths per year. Okay, but what about COVID? Again, we're trying to look at racial disparities with COVID. Well, let's look at historical information. In 2003, when the SARS outbreak occurred, we saw 2 times the mortality of people who suffered from SARS if they lived in a high pollution area compared to a low pollution area. Now, the interesting thing about this group is SARS occurred in East Asia. So there wasn't a lot of racial variety in those areas. This data was strictly based on pollution. But I just showed you in the previous slide that if you are a person of color, you are far more likely to be in a more highly polluted area. If you look at the outcomes in Italy right now from COVID-19, the highest death rates occurred in areas that had the highest levels of pollution. What about America? Well, there's 2 different studies that I looked at. One of them looked at defining an increase in particulate matter of 1 microgram per cubic meter. Another one looked at it in parts per billion, 1 part per billion increase. These are minuscule, nearly unmeasurable increases in pollution. And yet, just that small amount of increase in pollution, depending on the study, you either had an 8% increase in COVID deaths or a 15% increase in COVID deaths. So somewhere between 10 and 15%, roughly, people are dying at higher rates if they live in an area of high pollution. And I've just shown you who tends to live in an area of high pollution. One of the things that we talk about is, industry pollution, right? There are multiple reasons why people of color tend to live in those areas. And it's a little bit of a chicken and egg situation. So sometimes it's that people are able to afford things in that area. They tend to be lower income. People of color have a larger proportion of lower income earners in each racial group. And so what they can afford tends to be in areas that are lower priced. And the reason they're lower priced is because they're near industries and poor air quality and things like that, right? So that's one way that it happens. But another way that it happens is people are living in an area, but because they are disenfranchised and they don't have political power, it's far easier for industries to come into those areas. And these are very polluting industries and they're not regulated well. And so they can, with impunity, pollute the local environment. This doesn't just happen with industries, right? This happens with CAFOs and factory farms. So CAFO stands for Concentrated Animal Feed Organization. We know from large-scale studies that people put CAFOs, these industries, these animal agriculture industries, put CAFOs disproportionately in areas where poor Black and poor Hispanic people live. And those folks have higher rates of respiratory illness, cancer, heart disease, things like that. So this is not, unfortunately, new information, but it does explain, particularly when you're talking about a respiratory illness like COVID-19, why pollution is such a big player in explaining racial disparities. So there are some other issues though, right? So if you are relying on physical distancing to flatten the curve and slow the spread of an infectious disease, if you don't have the ability to physically distance, that's a problem. And people of color disproportionately don't have the ability to physically distance for two major reasons. So one of them is location, okay? So in urban areas, people of color tend to make up the largest proportion. Contrast that to suburban areas or rural areas where these places are disproportionately white, where you can physically distance. You can't really see it necessarily from my background, but I have a house where I'm fortunate enough to have a backyard. I live in a neighborhood where I can go for a run to help boost my immunity to decrease my chance of getting COVID-19. And I'm not likely to run into 15 different people in my neighborhood as I'm going for a run. So that's a privilege that I have that a lot of people of color do not have. Let's talk about multi-unit residential living. So that can be anything from low-income housing to just a regular apartment complex. Disproportionately, the people that live in these homes are people of color, right? And I mean, this isn't new information necessarily. We know that there have been laws on the books. There's been systemic and racial discrimination preventing home ownership for people of color. It's often hard to move into these neighborhoods to this day. Then you add to that the economic challenges of home ownership if you're a person of color. So none of this is new information, but it certainly explains why people aren't able to physically distance. So they're not able to physically distance at work because they're frontline workers, even though they don't have the protections they need. They're low income, so they don't get hazard pay, they don't have health insurance, and they certainly can't physically distance. Particularly, for example, we're seeing in meatpacking plants right now, we're seeing a disproportionate number of illnesses there, because how do you stay 6 feet apart if you have, thousands of animals that you're expected to slaughter within an hour, right? I mean, literally, those are the numbers. There's no way you could be 6 feet apart and still maintain those numbers, right? You don't have health insurance if you work in these industries. You don't have paid sick leave. You can't afford to not come in if you're sick. So you're already crowded at work, right? Regardless of the job that you're in, but you're also crowded at home. So you're also exposed to everybody else. But another way that you can't physically distance if you're a person of color is likely because you cannot telework. You disproportionately are unable to work from home. So Caucasians and Asians tend to be able to work from home, likely because they're working in IT or in management and administration and things like that. But if you're African American, only 20% of people are able to work from home. And this is from 2018. We know that sort of the flip side of looking at that is newer data suggests that 82% of African Americans are unable to work from home. So in 2-3 years, none of this hasn't changed. But we now have a pandemic, so it's much more of a challenge now. It's much more of a danger now that we cannot work from home, or that, I shouldn't say we, that African Americans cannot work from home. So remember, we talked about specific issues related to COVID-19 are that we know that poorer outcomes are associated with heart disease, diabetes, hypertension, lung disease, if you're immunocompromised or if you're elderly. Well, we've already looked at data that shows why disproportionately people of color are affected by these diseases. So that is a double whammy because those are the very diseases that are resulting in worse outcomes for COVID-19. So that's a specific racial issue that is related to COVID-19. Remember, we talked about ARDS in part 1. As a reminder, ARDS stands for acute respiratory distress syndrome. It's an acute lung injury. The hallmark of it is stiffened, often scarred down lungs. You have an inability to oxygenate and an inability to get rid of carbon dioxide. If you survive it, your mortality is still quite high, and you often have disability with it. But in order to survive it, you have to oftentimes be white, frankly. We know that if you are Black or Hispanic, you have a significantly higher risk of death with acute lung injury. Now, the interesting thing in a bad way about this is that if you are African American, the reason that you have a higher rate of death with acute lung injury is because you are more likely to be severely ill. You are more likely to have a more severe course of whatever triggered your ARDS, and you're more likely to have a severe course of your ARDS. So for better, depending on how you want to look at it, when you correct for severity of illness, that mortality difference goes away. I wouldn't say that's really good news though, because we still don't know why, or rather we still haven't addressed the fact that Black people are coming in sicker, right? Now, unfortunately for Hispanic patients, we're not seeing that effect goes away. We don't have a great explanation yet for why that may be the case. There is some emerging data for both African Americans and Hispanic people that there may be genetic polymorphisms involved. So that's a fancy way of saying that certain genes, when they're turned on, are associated with worse outcomes for ARDS. And we are seeing some data to suggest that if you are African American or Hispanic American, you're more likely to have those genes turned on than if you are white. We also know that Hispanics tend to spend more days on the vent than white people. So why am I talking about race and ARDS? Remember, a large portion of patients with COVID-19 are developing ARDS. So if you're developing ARDS for whatever reason and you're more likely to have a worse outcome and more likely to die, then that's a big problem if you contract COVID-19, because you're more likely to get ARDS from COVID-19 than you are from the flu. So another thing that we want to look at is sepsis. So sepsis is a fancy way of saying overwhelming infection. The reason that's important is we often look at sepsis and ARDS together because those diseases often present together. And again, it's a chicken and egg situation. Sometimes ARDS results in sepsis, sometimes sepsis causes ARDS. So what we know is that if you are Asian, you're less likely to die of sepsis. But if you are Black, if you are American Indian or Alaskan Native, or if you are Hispanic, you are more likely to die of sepsis compared to white counterparts. So again, if you are more likely to die of diseases that trigger ARDS or trigger COVID, or related to COVID-19, this is another reason why we're seeing worse outcomes with COVID-19. So in 2016, they did an interesting study that started to better delineate potentially why people who are African American are more likely to die from ARDS than Caucasian Americans. Some of this may be ventilator differences. So without getting too far into the weeds with this idea, When we ventilate people with ARDS, we use something called low tidal volume ventilation. And what that basically means is because the lungs are very stiff. Remember I said that in part one, if you blow too much air into the lung can actually pop. So we give people very low volumes, and we do this across the board, and we normalize it to someone's height, because that's how we determine what your lung size is, okay? But when we do things in a clinic, when I do pulmonary function tests, lung function tests on people, and these are tests that measure someone's lung capacity, their lung volumes, that kind of thing, we have to put race into the system. And the reason we have to put race into the system is because we know that on average, if you look at people of color, for their height compared to their white counterparts, they have smaller lungs than their white counterparts at the same height. Okay, so I mean, this just sort of goes to the historic racism of medicine, right? This is just another example. When you look at things that are normal, by and large, this is the normal for white men, right? This isn't the normal for women or for people of color, because nobody was studying them. Nobody was trying to figure out what is normal for an African American person. So it was only in the last 30 or 40 years that we've started to realize, oh, okay, no, we need to make this race adjustment. So we're starting to now look in studies with ARDS, are we actually doing that? When we put people on the ventilator, everything is mechanized, right? So you just type in the person's height, but are they also making sure that the race is put in there? Are we making sure that we're following ventilator statistics and that we're looking at pressures and we're making adjustments if we need to? And then again, as I said, there is evidence that there are genetic polymorphisms that may explain some of the differences between the various races for why some people do better and some people do worse. Okay, so it's a lot of information. I'm going to summarize some of the data from part one again, and then at the end, I'm going to talk about some of the things I think that we can do to hopefully improve chances for people of color. Okay, so again, COVID-19 is a zoonotic virus, meaning it's a spillover virus that is caused by our use of animals, as are all coronaviruses that have the ability to infect humans. And it causes a deadly disease with high infectivity. Younger patients are not exempt from severe illness. If you remember from part one, more than 60% of people who are hospitalized for COVID-19 are under the age of 65. Isolation is key to avoiding spread. It is the most important thing you can do, although I've just spent nearly an hour explaining why people of color don't have that luxury all the time. While masks do protect you from COVID, while masks do not protect you from COVID unless you're wearing an N95, which please don't be doing that, please donate those. They can protect others from you. So donate N95s, maybe don't donate surgical masks, but don't hoard surgical masks. Make sure you're wearing your mask properly, make sure you're wearing it over your mouth and your nose. Don't take it down to talk to people. Don't touch your face constantly when you're wearing it. Although there are no current proven therapies, meaning there are no cures right now, there are some experimental therapies that are ongoing in research trials that are showing a lot of promise, and we are starting to see some modest benefit from some of these medications, which I talked about in part one. So if you haven't seen that, definitely go back and watch part one. We do need more trials, and we need further analysis to determine the relative efficacies of all of these treatments. And again, the importance of flattening the curve is keeping hospitals at a level where they can handle the influx of patients so we're not overwhelming the system. Because if the hospital system collapses, the country collapses. So ARDS is a devastating disease, and COVID-19 is causing very high rates of ARDS as compared to other viral illnesses. There is a second disease pattern that is emerging with COVID-19, and this is one where there's a lot of clotting involved. And so we are starting to do therapeutic trials with blood thinners as well. If you survive COVID-19, you are often left with severe permanent disabilities and changes to quality of life, and that is why it is imperative to stay home if you can. So this is the slide that I was talking about earlier. So if you look at the social determinants of health, there are a wide variety of parameters that all ultimately feed into health outcomes, okay? And if you look at all of these parameters at every level. If you look at COVID-19, if you look at any disease process, there are wide racial disparities in healthcare outcomes. And this is due to a complex interplay of all of these factors in this slide. And the really disheartening thing is that every level of every one of these parameters, people of color are overwhelmingly disadvantaged compared to their white counterparts. So these are the things that need to change. So how do we do that? What can we do about that? There are a lot of things that we need to focus on. So these disparities result in worse outcomes for things like cardiovascular disease, type 2 diabetes, and these are direct and indirect contributors to poor outcomes for people of color with specific regards to COVID-19. So what are the things that we can do to potentially prevent this? Now, when I've given this talk to people before, I'm joking a little bit here when I say that the top 10 things you can do are stay home. Now, I've just given you a talk about why people of color don't always have that luxury. So I've modified this to say, stay home if possible, okay? When you're not at your job, if you have the ability to stay home, okay? If you're someone who's working 2 jobs, that's a different story. You don't have that luxury, okay? But minimize your trips to the store if at all possible, okay? One thing that we can do is now is not the time to start opening back up, to start going to hair salons, going to nail salons, having parties, having barbecues. Now is not the time to be doing that. I realize that's an easy thing for me to say if you are locked down and you've been working 1 job, 2 jobs, 3 jobs, and you have no sort of pop-off valve, no stress relief. It's very tempting to want to go to do these things. Unfortunately, the benefits of doing those things are far outweighed by the risks of doing those things. Practicing good hand hygiene and hygiene in general is going to be hugely important. So frequent hand washing. The vast majority of people do not wash their hands properly. You can go to something called washyourlyrics.com. Wash as in, wash your hands. And it's called washyourlyrics.com. And some kid in the UK created this website where you can type in any music artist and any song, and it will display the poster that the National Healthcare system in the UK uses for hand washing. And it actually shows you proper hand technique, and it breaks it down by lyric, okay? So that's the way you should do it. In America, we typically say, sing the happy birthday song twice. That's about 20 seconds. But if you want to use a different song, use a different song, go to washyourlyrics.com. Make sure that you don't do what I just did. Don't touch your face constantly. So a lot of people are freaking out about, for example, going to stores, and so they're wearing gloves and they're wearing masks. Here's the problem that I'm seeing. Someone's wearing gloves, so they think they're protected. They touch something on the shelf, and then they put it down. But then their face might itch because they're wearing the mask, so then they move the mask. Well, the glove is contaminated because you've just touched something. So wearing gloves is less important than just being very vigilant about touching your face when you're touching other things. So if you touch other things in the store, under no circumstances should you be touching your nose, your mouth, your eyes, because these are all points of entry, right? We often talk about the nose and the mouth, but we don't talk about the eyes. If someone coughs in your face and you get a droplet in your eye, that is absolutely a potential infection site, okay? That is a way for the virus to get in. So hand washing, don't touch your face, wipe down commonly used surfaces. If you don't have hand sanitizer, that's fine. I have exactly 0 bottles of hand sanitizer in my house because I'm allergic to it. So I use soap and water. If I have hydrogen peroxide, I use that, but soap and water works fine. You don't need to have fancy wipes and things like that, okay? You just need to lather it up again for 20 seconds. In fact, soap is superior to hand sanitizer because it actually causes the virus to explode. It literally breaks down the protein coat of the virus. So again, initially we were saying you don't need to wear a mask, but that was because we were hoping that people would follow lockdown procedure and that the government would aggressively implement lockdown, and they didn't. So now we're stuck with, we're not locking down like scientists and physicians think we need to be. And so now we need to wear masks so that we can protect each other from us, okay? Maintain at least a 6-foot distance from others when you can. I don't have a good answer for people who don't have that luxury, for people who work in jobs where they are going to potentially have retaliation if they complain about those things. I honestly don't know what the right answer is for that. It's disheartening, it's disturbing that that exists, but I know it does. Hopefully, as I finish this up, I don't know if Brenda has other resources or options, but if you have the ability, stay 6 feet apart. So let's talk about other tangible things that we can do. We can boost our immunity. So people in lifestyle medicine, I think, sometimes exaggerate the ability for us to boost our immune system. But we do know that if you eat a whole foods plant-based diet with little or no oil, there are tangible effects that can decrease your risk of getting COVID-19, and if you do get COVID-19, of having a bad outcome. Eating a whole foods plant-based diet or being vegan is not like a magic cure. You're not invulnerable to the virus. You absolutely can get the virus if you are vegan or if you eat a whole foods plant-based diet, okay? But when you eat a whole foods plant-based diet, you directly, or I should say indirectly, reduce your risk because you are reducing the risk of comorbidities that are associated with worse outcomes, like hypertension, type 2 diabetes, cardiovascular disease. So if you don't have the diseases that are likely to increase your risk of a worse outcome, then you are much more likely to do better if you do get the disease. There is some evidence that certain foods improve immunity. So for example, there's a study that shows that if you eat blueberries, it does actually have a direct effect on natural killer cells, which are an important immune cell, okay? So the last point I have here is question mark nitric oxide benefit. So if you remember from part 1 of my talk, I talked about inhaled nitric oxide as a therapy for ARDS because it improves oxygenation. We're also starting to see that inhaled nitric oxide may actually prevent the virus from replicating because it doesn't like being in a system where there's nitric oxide. Well, we know that when you eat certain plant foods like leafy green veggies, we actually promote nitric oxide synthase, which is an enzyme that we all produce, but we boost that in our bodies when we eat leafy green veggies. And by boosting it, we boost the release of nitric oxide. Nitric oxide is beneficial to our blood vessels. One of the ways that we believe that a whole foods plant-based diet reduces your risk of heart disease is because when you eat lots of leafy green veggies and fruits that have high antioxidants, you're healing the blood vessel walls, the endothelium. The endothelium is responsible for the release of nitric oxide. So this is another potentially tangible way that a whole foods plant-based diet might protect you. There are no studies that suggest that eating a whole foods plant-based diet and therefore increasing your nitric oxide is going to prevent you from getting COVID-19. I don't want people to misunderstand what I'm saying. I'm saying theoretically, we do improve protection because we improve our own nitric oxide stores. So exercise is another way that we can tangibly improve our immunity. So there have been studies that show that if you do moderate exercise, you actually boost your white blood cells and you boost their function, okay? Now, that only persists if you do consistent exercise. So you can't exercise once and then think that you've got permanent immunity. You have to have a regular exercise program. The current recommendations are a minimum of 150 minutes of moderate exercise a week. If you do more than that, that's better. So let's talk about somebody who maybe doesn't have the luxury of doing that, because you may be someone going, all right, great, doc, that's nice of you, but I work 3 jobs. You probably don't have a lot of time on your hands, obviously, if you're working more than 1 job. You may not have a lot of time on your hands if you are working 1 job, because you may be coming home and then also being responsible for children or companion animals or elderly people in your family. So it's important to understand that when we talk about 150 minutes, it's not like you have to do 50 minutes 3 days a week or 50 minutes continuously or 30 minutes continuously. Find 10 minutes 3 times a day to do something that gets your heart rate up and gets you breathing a little bit fast. Now, if you're someone who's never exercised before, or you carry a significant amount of excess weight, you need to talk to a physician first, because it's possible that they might want to do a stress test on you to make sure that you can even tolerate exercise, right? I'm not trying to give you medical advice. Nothing that I talk about today should be considered medical advice from me to you. You do have to go to your own doctor. But we do know that exercise benefits people. If you start to notice dizziness, chest pain, nausea, you're unable to speak in complete sentences, stop exercising and speak to a medical professional before you start again. Get plenty of good quality sleep. So again, these are very stressful times. It is very hard to sleep restfully when you are stressed about putting food on the table, when you are stressed about your mortgage payment, when you are stressed about the fact that you work a high-risk job and you don't have adequate protections. If there is a way that you can get a minimum of 7 hours of good quality sleep, that's important. One of the things that I like to do, because sometimes when I come home from work, I'm freaking out about exposures, or I'm freaking out about, my brother is a pharmacist, so I might be worried about his risk exposure, and it's hard for me to shut my brain off. I listen to guided meditations at night that kind of help me to calm down. There's a really decent website called doyogawithme.com, and their guided meditations. They have one called Yoga Nidra. I don't want to really necessarily call this an endorsement. I'm just saying that it works for me, and it helps to kind of calm my mind. And I notice that I sleep better on the days that I do that compared to the days that I don't. Speaking of stress, we know tangibly that stress reduces your immune system. When people are stressed out, they're more likely to get colds, they're more likely to get other illnesses. So it is very important that to whatever degree you can, you reduce your stress. Whether that is waking up every morning and creating a gratefulness journal, whether that is spending just 2 minutes, set your watch timer, your phone timer for 2 minutes, where you just practice deep breathing exercises. I personally meditate. It's been shown to really improve stress levels, and it tangibly changes blood pressure parameters and things like that. So if you have the ability to do that, do that. Even if it's just 2 minutes a day, even if it's just 5 minutes at night, you will notice over time that you'll get better at it, and it will continue to improve your health. Mindfulness is another thing that I recommend to people. If you happen to be in healthcare and you have what's called an NPI number, Headspace, which is an app for mindfulness and meditation, they're offering free memberships to anybody in healthcare with an NPI number until the end of the year. But there are plenty of free mindfulness apps online. You can literally just Google guided meditation. It takes a little bit of work because sometimes the voices, they just are not relaxing to me. So you have to find one that works for you in particular. But even if it's just 5 or 10 minutes, if you happen to be someone who takes a subway home from work, and you have a tendency to listen to music, maybe listen to some mindfulness meditations or guided meditations. Just make sure you're somewhat paying attention to your surroundings so you don't miss your stop. But find small ways, if you can, during your day to reduce your stress. It's important while physically isolating that we don't socially isolate. So particularly if you have elderly people in your family that you are unable to be with right now, make sure that you are still communicating with them. The millennials are going to freak out by this statement, but texting does not replace hearing someone's voice, especially if someone is elderly. So if you're wanting to talk to your grandma, don't text her. Pick up the phone and call her. If she has the ability to video chat with you, video chat with her. Physical isolation is resulting in a lot of worsening of mental health, and we know that worsened mental health results in worsened physical health. So it's really important that we do practice self-care to whatever degree we can, and that does involve keeping social connections because we know that that strengthens your immune system. And again, as we talked about in part 1, avoid risky behaviors like smoking and excessive drinking, because we know that those increase your risk of making your lungs vulnerable to COVID-19. So because I am vegan, I am going to say that we need to stop commodifying non-human animals at all levels, because that's going to reduce future pandemic risk. It improves human and planetary health, and it improves animal health. How does it improve human health? Well, not only does it improve human health, because if we're not eating animals, we're not getting the diseases caused by eating animals, such as heart disease, many cancers, stroke, type 2 diabetes, okay? But we're also no longer contributing to the environmental racism and the detrimental effects of CAFOs to people of color. support vegan food justice organizations. It's really important. It's all well and good for me to say eat healthy. If you don't have the ability to get that food, that's a big challenge. I'm part of a group right now that's creating an app that our hope is to tie in people who are hungry to restaurants who will donate plant-based meals. So you buy a meal and you donate a meal kind of situation. But there are many organizations. Brenda has some phenomenal organizations that are working on getting food to people who need food. And it is vegan food. It is healthy food. Chili's on Wheels is another one that has chapters all over. There's an organization in Atlanta that I'm completely blanking on the name of that's run by a phenomenal woman who gives out, hundreds of meals to homeless people every weekend, and they're plant-based meals. So support vegan food justice organizations, support any organization that currently is hurting that is promoting veganism and whole foods plant-based. And the only reason I say that is I don't think it's in our best interest to promote organizations that are feeding people the things that are making them sick. And then of course, use your vote. Okay, so we need to be voting for people that are pro-science, who believe in things like climate change, who believe that COVID is a real virus and isn't a hoax. We need to be voting for people who support universal health care, who support a living wage, who support a universal basic income, who support pensions. We should not be a country where if you lose your job, you don't have health care, where you don't have the ability to retire. Every other country, every other major country is able to do these things. I worked in Australia for a year and they gave me a pension for that year of work that I did, okay? I had guaranteed healthcare for the year that I worked there. I never had to worry about healthcare. We also need to be fighting for better pay and housing and healthcare equity, of course. I mean, this entire talk is about how economic inequity and healthcare inequity is a direct contributor to why people of color are doing worse with COVID-19. So that's a lot of information. I hope it was useful to you guys. I'm gonna end the talk here. And I'm happy to answer any questions.
Wow. Wow. I just
a lot of information. I'm sorry. I hope it wasn't overwhelming.
No, not overwhelming. My brain is buzzing. There's just so much information. I'm definitely gonna go back through with a pad and a pencil and take notes, and I'll probably rewatch these over and over again, because there was just so much really powerful and important information there. And so just thank you so much. Thank you so much. I've heard a lot of people speaking on this topic, and I've even heard some physicians speaking on this topic who just didn't seem to have as comprehensive of an understanding of just the lungs, or viruses, or how all these things sort of come together. So I mean, I'm so grateful that you took the time to do this today, and also would like to make you an offer, because Afro-Vegan Society created what we're calling our speaker series. Mm-hmm. And so I would love to invite you back and have you speak on some of the other topics that you are so well versed in and so knowledgeable of, because you are actually quite a compelling speaker. I don't know if you identify as such.
I'm not a fan of public speaking in the sense that, this is easier for me, right? I was somebody who actually, honestly, in residency and fellowship, I've had to give lots of presentations. I've had to do scientific talks and publish abstracts and stuff. And I was always a person who'd go throw up in the bathroom before giving the talk.
Wow.
And it changed for me a little bit now, because once I started doing lung transplant, I realized I was the expert in the room amongst general pulmonologists, and that changed things for me. And similarly with lifestyle medicine, now that I'm speaking publicly, often to non-physicians, it's a little less nerve-wracking, right? For example, if I'm a pulmonary fellow and I'm in a room with pulmonologists who've been pulmonologists for 50 years and who are publishing the data that I am showing people. It's really nerve-wracking. But I do enjoy it now. And I think part of the reason I enjoy it is a friend of mine who is very much sort of a tell it like it is kind of guy. He absolutely was like, listen, the animals, so I'm going to swear here for a second, so bleep this out if you need me to. But the direct quote from him was, listen, the animals don't give a shit about your insecurities, right? Oh, wow. So you're going to use your medical degree to be an activist. And that's what I try to do. I try to use my medical degree to debunk the number one reason people say that they cannot stop eating animal products, right? Which is you need it for your health. Right?
Right.
Well, I'm here to say, as someone who's been studying nutrition for 9 years, who's board certified in lifestyle medicine, that not only is that not true, the converse is true, that eating animals results in poorer health, right?
Wow, exactly.
So it's really important that I use that background. Like, nobody cares about my opinion about climate change. I'm not a climate scientist, right? But people do tend to listen when I talk about that. And so, yeah, I mean, listen, your organization is phenomenal. One of the things that is really important to me is I think it's very easy if you come from a place of privilege to have good health, right? Because you have access to good food. And I mean, I don't shop at Whole Foods, and I don't shop at Whole Foods for a variety of reasons. One of them is I think Jeff Bezos is the devil, but that's a whole other talk.
Yeah, it sure is.
But, so there are a lot of things that I don't do, but I have the ability to do those things, right? I have the ability to have good health. And many people I know have the ability to have good health. But that's really offensive. I mean, every single person, everybody deserves good health, regardless of their socioeconomic status, regardless of the amount of melanin in their skin, right? Regardless of where they live. And so the fact that we're eating animals, and that is actively promoting food injustice, right? Because we're using up resources to feed animals in an inefficient manner. I mean, I think what you are doing is just so profoundly important. And, as when we met at Atlanta Veg Fest, you were the speaker that I could not wait to hear.
Oh,
Atlanta Veg Fest. Like, I was tired by the end of the day because I'd already given my talk and I'd sat through a bunch of talks and I'd volunteered at a booth. And I was like, I got to go to Brenda's talk because I followed you and what you're doing for so long. So, I mean, I think we have a little bit of a mutual admiration society on here. But yes, I would be honored to be involved. I was honored that you asked me to do this talk. And I have to thank you not only for inviting me to do the talk, but in doing the research, I knew a lot of this data. I mean, I sort of abstractly knew this information, right? But to see some of the actual statistics was just horrific, right? I mean, so something I did not know. I mean, I knew that African Americans are discriminated against from a housing standpoint. I had no idea that there was a study out there that showed that if you're African American, you're 4 times more likely to be evicted from your home, regardless of your income, right?
Wow.
I mean, so, knowing that stuff. So I want to thank you for teaching me by having me do this talk. I learned a lot doing the talk.
Awesome. And I know people are gonna have so many questions. Is there a place where they can email questions to you, or should they email them to us and we pass them on to you? How can they?
So can I make a suggestion? I don't know if this would work for you, but do you want to maybe post them, and then in a couple, like once you've posted the videos, maybe in 2 to 3 weeks after that, we do a Q&A.
That's a good idea. Okay. All right. So let's plan for that.
Because the only reason I say that is if so you can follow me on Instagram at _the-veg-doc. I'm the veg doc on Twitter, and that's just because some random person on Instagram has the veg doc. I don't understand why. They're not vegan, they're not vegetarian, they're not a doctor, but that's their handle.
Oh no. Wow.
So I'm _the-veg-doc on Instagram. And the thing is, if I get 30 of the same question, I'd rather just be able to sort of, because I'm sure multiple people are going to have the same questions. So it'd be nice to, if anybody is interested, I'm more than happy to answer those questions in a Q&A.
Okay. Well, that sounds great. All right, so I mean, this concludes this wonderful, wonderful information session that we just got into here. And I just want to again thank you so much for taking the time to do this. It's been so illuminating, and I'm so thankful that we have now this information to share with others.
Thanks so much.